Welcome to the Bioptimizers Awesome Health Podcast. And now here's your host, Wade T. Lightheart.
What if you could double your energy naturally without caffeine or stimulants in just 3 short months? It's not only possible, you can transform every aspect of your health if you follow the 12-week blueprint we've created for you in the Awesome Health System. The Awesome Health System is a free course where you receive a daily video lesson spanning the most cutting-edge secrets for air, water, exercise, sunshine, optimizers, mindset, and education. It's something most companies would charge hundreds of dollars for, yet you get it for free when you go to bioptimizers.com. To access your course, register to download the PDF report called 3 Phases of Bioptimization, which gets you access to the report and daily access to the first lesson in the 12-week, 84-day Awesome Health course.
Good morning, good evening, good afternoon. It is Wade T. Lightheart coming at you live from Venice Beach, California, and I'm joined today by Julie Siemers, who is going to address an issue that is near and dear to my heart. And if you look at the medical data in today's world, I think it's either third or fourth, depending on what source you cite, is that medical error is the third leading cause of death. And as someone who's concerned about their health, there is a seismic chain or chain reaction that is now underway in United States and will probably follow through to the rest of the world. So what we are here to do today is help you get informed and educated how to advocate for themselves and for your loved ones. So for example, I've had some situations with my father who had a heart condition that was treated through surgery, and then he was put on medications that were complicated. When I did an analysis on it, we determined that there was many of these elements that could be addressed through other means, which we did, and corrected all the elements to the surprise of his medical doctor. And she was impressed with the results and was able to do that. And I've seen this happen literally thousands and thousands of times throughout my history. And our goal at Bioptimizers is to help bring you cutting edge information to understand how to advocate yourself when maybe you're uncomfortable dealing with a doctor or person of influence who is in your life who is maybe suggesting things that could potentially lead to medical error. One of the other elements I would suggest is always, whenever prescribed with any medications, to really thoroughly have a long discussion with the pharmacist, who is often more abreast of the elements that your doctor might not. The doctor is there to prescribe things or suggest things based oftentimes on marketing dynamics that they're subject to or through directives through their governing bodies, but may not be aware of some of the contraindications and problems that do lead to death. And the fact that it's third or fourth leading cause of death determines certainly that this is something that you need to pay attention to. And so fortunately today we have Dr. Julie Siemers, who brings more than 40 years of invaluable healthcare experience to her mission of saving patient lives with a profound commitment to patient safety. She utilizes her extensive nursing background and education to transform healthcare culture, and we are in a seismic shift right now, as I indicated. So to tackle preventable patient harm, the third leading cause of death, she authored Surviving Your Hospital Stay. And I can't recommend getting this book I can't recommend it enough, I should say, to getting this, especially because as people age or they run into challenges, I think the disability adjusted life expectancy is about 60 years old right now in the United States, and life expectancy is going down, oftentimes due to these contraindicative elements. The idea of surviving your hospital stay is to empower patients and their families. So through Julie's speaking engagements and consulting work, she strives to educate others, reduce medical errors, and enhance healthcare safety and make you the healthiest version possible. And we've been on that mission for over 20 years, and we're excited about some of the changes that have happened in the political sphere and a new emphasis on truly providing health care. But the big element is for you to take on the advocacy of the listener. You have to become and recognize that your doctor, your pharmacist, your primary caregiver is an advocate and an advisor. You are in control. That's the first primary element that you have to recognize. And I always suggest, if I make a business decision, I go to 3 or 4 different people and get competing perspectives so that I can make a better choice rather than just go to a single one-off. So, Julie, thanks for joining us on the show today. I'm really excited to have us on the call.
Thank you. I appreciate being a guest on your show.
So maybe before we get into the heavy topics, we might want to go back to your background. What drove you from your experience, your history, you can kind of talk about it, to actually write this book, Surviving Your Hospital Stay? I have a suspicion there's an element in there of a personal story that you would like to share with our listeners.
Yeah, I was a nurse for probably about 10 years, and my parents had an airplane accident. And my dad built a small little 2-seater in his garage, but he flew it for like 6 years. And then they had an accident. They both survived, but I was living across the country and I couldn't go be by their side. And I was petrified for their safety in getting good care. And the problem with that too is they would not speak with any of us except my brother. There was we had a big family. And so they chose my brother, but he had no healthcare background. And so it was really trying to decipher what was really going on and trying to help and intervene and communicate, which was challenging. They survived, thankfully, like I said. And then when I started my master's degree back in 2009 and my doctoral research, I chose the topic of patient safety because when I was teaching students and using case studies as examples, and they were of patient harm, that research brought me to the level of understanding how big this problem actually is. And I think the other disturbing thing that I learned is it's been going on for decades and we have not improved. We have not solved a little bit of this problem even. Yes, our healthcare acquired infections are down a little bit, but not significantly. But that's only one sector of patient harm. So that was kind of the genesis back in 2009. And what led me to write the book is seeing at the bedside so many patients and their families having no healthcare background and not even being able to understand the medical jargon, and nurses and doctors being so busy flitting in and out of the room. The family and their patients have no idea what's going on. And therefore, how can they take the information they don't understand to learn how to, as you said earlier, how to advocate for themselves? So that's why I wrote the book.
Yeah, I got turned on to that whole element. I can recall when my sister was in hospital care as a young man. It's one of the reasons I got into healthcare. She died at 22. They would be coming to her bedside, and she was in a severely compromised state, going through chemotherapy and radiation treatment and stuff like that. And then sometimes the drug suggestions that were given to her were essentially lethal. And she was picking this up on her own in a compromised state. She had a disagreeable type personality, which is more inclined in order to identify and to be able to advocate. That might not be possible as a patient. And then as a family, I have a number of friends that, their children or family members have gotten into situations, and you start getting this jargon within the medical industry, which is very complicated. And it has a psychological impact on the people where they want to be able to help, but they realized, well, I have no idea what they're talking about. I have no idea. I've been assured that this element is going to work. But the data suggests that many of those recommendations are actually dangerous and in this case, proven to be lethal. And our medical industry, and I think it was in the Senate hearings recently on Capitol Hill with HHS director was identifying that the political subset in society has primarily focused on about 8% of the issues that people are dealing with from a health or critical care element. And so I think we have very good critical care. You get hurt, you get in a car crash, you need a surgery because of some key element. World class, and the developments, I would say, from a longevity perspective, are primarily based on those elements. But the evidence suggesting for quality of life, healthcare, and these risks of death the data is not that supportive. And I like that there's now a movement to start adjusting. Well, why, if you look at heart disease and cancer being number one, number two, diabetes, number three. Well, all those are dietary based, primarily in combination with genetic preconditions. Plus, there's other elements about toxicities, et cetera, et cetera. What's fascinating, and they didn't mention it, and I expect you have some history, is the contraindications about medications that oftentimes patients might be on, and the unanticipated complications, because oftentimes those studies are not available or haven't been done about the interactions or the long-term detriments of taking some sort of element. So when you get into the book, so what are the primary elements that you're discussing, maybe as a step one, step two, step three? Here's how you become your own best health advocate, because we're all going to end up in that situation. Death is certain, and it's usually a unfortunate and messy and complicated emotional element where you're going to get exposed, because same thing as we get a plumber in the house. If the pipes break, I don't know how to fix the plumbing. I get someone in here as an expert, and I trust that person to do it. The problem is I can get another plumber to fix my job. If he doesn't get it running, I lose the money. But in this case, you could lose your life.
Right, exactly. So to start out with, I think understanding that each hospital has a safety grade. I think that's really important to know, because I didn't even know that as a healthcare provider. But there's a website, hospitalsafetygrade.org, and you can just put in your zip code of where you live, and you can see if your hospital that you would normally go to or is closest to you is rated an A, B, C, D, or F. There are 22 subcategories, patient safety categories, in that website, where you can actually see, are they red, yellow, green in each of those categories? For example, there's a category about surgery. What are the outcomes of preventable blood clots at this hospital? So I would, for sure, you can have the best surgeon in the world doing the surgery on you, but that's only a piece of the puzzle of whether you come out of that surgery and hospitalization better than when you went in, which is our goal, right? So that's a piece of it too. Finding a provider that respects you and that you can have a one-way or two-way conversation with, that, as you said earlier, if you want to go get a second opinion, they support that, because put themselves in your shoes, they would do the same thing. And then I break down the chapters into various things you may run into in the hospital. Vital signs are really important. And I think it's an indicator of clinical instability that is missed many times. The research out there says that the physiological indications of clinical instability or beginning deterioration occur 6 to 24 hours before an unplanned cardiac arrest. So those indicators, if you become educated and informed as a family member or even a patient, you can help the nurses and the doctors by watching for those things. Neurological changes. Hey, my mom isn't acting like she normally does. Hopefully that'll inspire the nurse to say, oh, well, what do you mean? And investigate further. When you don't have the family in the room to say that, it may be lost until now we have severe deterioration or even cardiac arrest. And there's 30 stories in the book. I know I relate to stories. They're all true. Unfortunately, most of the patients in the stories died. But I give those examples for you as a family member to say, oh, if that happens, I know, for example, if grandma had a stroke and she's got a tube feeding going down her nose to feed her nutrition, her head of the bed should never be flat. So if the nurses come in and do a bath or do a bed change and then leave the room and the head of the bed's down flat, that's a risk. And you either call the nurse back in or you put the head of the bed up yourself to prevent aspiration. Those kinds of tips and tricks.
Wow, that's really potent, because even in a mildly compromised state, that's going to make a big difference on oxygen levels. So for example, if you're going into anesthesia, one of the elements that they're testing for, are you taking medications of a certain category? Are you a smoker? Are those elements, because that becomes a very determining factor of how the anesthesiologist maintains sufficient amount of oxygen so that you don't run into complications or trigger cardiac arrest or stroke or some other debilitating condition that can happen from the surgical aspect. What are some of the other things that you have noticed in your history here, or maybe you can highlight that is common elements that people would, get faced with?
Diagnoses, there's multiple errors in diagnoses, and they say about 33% of emergency room diagnostics are wrong or missed. There is a story in my book of a woman whose husband went into surgery for a brain tumor. They told her and him after surgery, don't worry about it. The tumor looked benign. Well, the pathology report that was written or, come from the lab got misfiled. Nobody was notified. And 6 months later, when the patient is having, again, raging headaches, and they do another CAT scan and find out he's got a tumor the size of the surgeon's fist. And that's when they find the misfiled pathology report indicating he had cancer. And so even blood work that you get your results, and don't give up in trying to talk to the doctor about what those results are, and then get a second opinion, as we talked about earlier too, especially if it's a diagnosis that's quite surprising or shocking, or has medical consequences, health consequences.
Yeah, and I think a lot of people automatically assume that, just going for surgery and it's all case. But you have to realize that that's about as close as death as you can get, even for a mild anesthesia condition. For cosmetic surgery, there is an element of risk. But when you start getting misdiagnosis, or you get into an area that's much more complicated, it's heart, your brain, some of these essential organ, liver, all this sort of element, 33% misdiagnosis. I mean, that's pretty poor. That's a pretty poor track record. So basically, if there's 3 people listening to this, one of you are going to be exposed to a misdiagnosis and may go down a route that is essentially lethal or unnecessary.
Yeah. And let me preface all this. I guess I should have said it in the beginning. I'm not here to throw anybody under the bus. I'm not here to throw shade on the profession. We're human and we make mistakes, but most of the time, if the hospitals would trace that error or mistake back to, it isn't just a single person, there's multiple systems errors that allowed that to happen. Take, for example, the case of Redonda Vaught, the nurse a couple of years ago. It was all over the news because she went to jail for it, gave a paralyzing agent to a patient getting a CAT scan instead of a sedative. Vanderbilt fired her. They settled with the family and they wrote natural causes on the death certificate. When they did, anonymous tip came in, and that's when they did an investigation, and they found, the automatic dispensing cabinets were not working correctly, and all the nurses had to do overrides, which means they're trying to get into it the back way, and it takes off safety guards. They found about at least 6 errors. Another one was she was brand new. She was floated down to the radiology department. She was mentoring a brand new nurse. So when we point the finger, it feels really good to say, that's the reason she did it. Mm-hmm. But in reality, we don't solve the problem. And so I just wanted to preface that by saying, this whole talk about, I really want to inform and educate people so that we can work together with the healthcare system, that we can partner and really create that bridge between communication. As I said in my TEDx talk that came out last month, 70% of patient harm the Joint Commission has determined comes from communication breakdown. So that's either communication with the healthcare team itself, the doctor to nurse, or with the family included in that breakdown.
Yeah, I think if you look at the failings in human society on a lot of levels, it comes down to the failures to communicate inside of that, whether it's pre-biases, communication issues, language issues, cultural issues, social issues, unresolved psychological perspectives, etc., the inability to listen, the inability to ask questions. And this is, I think, really what happens, because there's a sense of helplessness that happens to the person. And there's also a deferment of responsibility. And and to echo your point, you have to realize nobody gets into the doctor or medical field to kill people. They're some of the most empathetic people in the world, and they're excited to be in a position that they can, save lives. But they're also subjected to governing bodies. They're subjected to procedural elements. There are pressures at time. Maybe there's a lot of people on sick, and that nurse or that doctor is taking on a disproportionate. They might have other elements that are contributing to a disruption in their analysis or their thinking process. Then you have the administrative elements that can go wrong. So you have to realize that presenting, I think, and maybe we can talk about this, is in your advocacy. One of the things that I've had to learn over time is to be able to enter into the conversation from an inquisitive and logical aspect, which oftentimes when you're in those situations, they're very emotionally taxing. They're very traumatic. Or you have to make decisions very quickly. I'll give an example. Recently, we just had a baby boy, and I had done a home birth. So we had a whole bunch of naturopathic doctors and masters in nursing, and the support personnel in a special location, and had all the medical equipment with we had everything we need. Well, anyways, child got hung up and wasn't coming out, even though everything was proceeding great. Then my wife was stuck in labor, and we had to take an ambulance to the hospital. We went into the doctor's realm, and we got in there. And what was really valuable about that is my wife and I had a long discussion prior to about what happens if this goes on, what happens if that. So we were preemptively ready, and the birth turned out totally different than we anticipated. When we went into the medical element, my son was getting choked off, and usually they can unwind the cord, but it turned out the cord was wrapped around his waist 3 times, around his shoulder, around his leg, around his neck. But there was no way this kid was coming out. We had no way of determining that. The doctor at that moment didn't know how to determine it when we were in the medical room. I watched him go through his rational elements, looking at the monitors, all this sort of stuff. And in that moment, because we were so prepared, we did make the decision for surgery at that point, save my son. And then we discovered that there was no way that we could have figured this out. So it wasn't anybody's error from our care team. It wasn't the doctor's error, but we were prepared going into that. And I think a lot of people aren't prepared. And a book like this can really help them be prepared for the inevitable that you're going to be subject to a condition. There's a very high likelihood you're going to be subjected to a condition like this.
Yeah, and congratulations. And so glad things turned out beautifully and well. But yeah, you're exactly right. And that's what I say to people too. Don't wait till you're in the emergency situation before you start learning about your medications, your health, your disease. I'll give you another example. There was a patient who had sleep apnea. It affects millions of Americans. 80% of people don't even know they have sleep apnea. He had shoulder surgery, and postoperatively, they gave him opioid pain medication, which is, appropriate. But opioids cause respiratory depression. So the combination of respiratory depression and sleep apnea, because sleep apnea is a breathing problem, even though it happens at sleep time. And so because he had no other comorbidities, the nurses didn't keep a close eye on him and just thought he was sleeping. Well, he was, but during that time of the combination, his respiratory rate slowed down, and then the CO2 builds up, the carbon dioxide. And the next time they checked on him, he was dead. So it is understanding your condition, doing the research, and we're so fortunate to live in a day and time where we can find out so many things at our fingertips about our, chronic disease, our health, our, as you talk about, how to stay healthy so we don't get to some of these places of chronic disease, but also what to expect and be prepared. That is your best weapon to stay safe.
I was very interested in a conversation I heard Gary Breckett talking about recently in insurance actuary. So he's advocating for preventative maintenance of the body long term. And what's interesting about insurance actuaries is basically they have a lot of data on mortality rates. But what he revealed in that conversation is that once you start going on medications for a variety of elements, your premiums and expectancies take a dramatic shift because they know with the massive amount of data that they have that, okay, you're on this stuff, you've got 7 years. If you're on this medication, you've got this. No, because what people also fail to recognize, if you go to the New England Journal of Medicine, it says, we don't cure disease, we treat the symptoms of disease. That's right I remember reading this textbook 30 years ago.
Exactly.
And so, for example, in a case like if you're on a sleep apnea situation, well, there's an inflammatory problem that is actually your responsibility that oftentimes can be addressed with diet and exercise or certain elements that you can integrate. Maybe it's saunas, etc. Who knows? There's a variety of modalities that you can implement and take action on preventatively side. But to recognize that when you take the medication, very seldom do they actually give you the data on what that means for the long-term consequences. It solved that interim problem. And when you get out of that immediate care area, now it's like, well, I'm on this. And, I was able to remove my father, for example, off several different medications, which were approved by his doctor because he was able to change the elements using techniques that we advocate for in Bioptimizers that were outside of the purview of the doctor. So there's things that, and no one's going to take care of your health better than you. What are some of the elements also that you think are key in people addressing this issue as they, as a proactive element of preventative care?
I think as you talk about, and I love your work, I've been following it for a long time as well, is prevention is the best medicine. But we also know chronic disease is a huge problem in our country for the last 50 years. And part of that, as you know, I'm sure too, medical school, only about 20% of medical schools actually have a course on nutrition, and that may be just one course. So physicians really aren't trained. The big pharma really helps contribute the curriculum for medical schools. So understanding that, I think, is part of owning your own health. But if you do have chronic disease, that is again where how can you optimize your health to get off some of those medications? And unfortunately, I think people have gotten used to a quick fix. And a pill can solve a blood pressure problem or a blood sugar problem. But, as we've talked about too, the pharmacology always creates another problem, like the high cholesterol medications can cause all sorts of problems that, sometimes just get minimized and really isn't the best thing for you. Again, when we're talking about the hospital, I think understanding what the proactive things you can do is very powerful. Medical error, another example of that is wrong site surgeries. It happens about 20 times a week across the nation. You would think having frontline news that says man's liver was removed instead of his spleen, which caused death, would be a big red flag to surgeons going, I better make sure I'm doing the right surgery. Just a couple of weeks ago, I wrote about a patient who was supposed to have his right knee replaced and had his left knee replaced instead. And so it's just knowing those things can happen really allows you as a consumer to have those conversations with your surgeon. Just for example, you could say, I understand wrong site surgeries occur. How are you going to ensure that you take out the correct kidney, my diseased left kidney, not my right? Or how are you going to help prevent blood clots after surgery? I know there's protocols. What do you use? And it's really having those real conversations with your physician that is going to really facilitate, I think, the best care that you can get.
At Bioptimizers, our mission is to fix digestion. And a cornerstone of digestion is gut flora. P3OM is our patented probiotic formula. In fact, we call it the Navy SEALs of probiotics. You see, strong proteolytic or protein digesting activity is paramount to having a healthy gut flora. And of course, P3OM provides that. The good news is, unlike weaker probiotics, P3OM survives the digestion process. What it does is it basically multiplies the good guys while protecting you against pathogens, or what some people call the bad guys. P3OM really helps to rebuild your digestion. And what that allows you to do is to maximize nutrient uptake, energy, and metabolism. To find out more of how P3OM can help you, go to www.bioptimizers.com.
I have a question for you that's coming to the forefront of the news right now, and that is the developments in AI, data crunching, diagnosis, as well as elements. What do you see happening with the use of AI or the misuse of AI? I think it's always a double-edged sword. What do you see happening there as far as for patients' advocacy?
That's interesting. I just got home from a big conference put on by the Institute for Healthcare Improvement. It's called the Patient Safety Congress in San Diego the last couple of days. And there was a speaker on, he was from UCSD on this topic exactly. And I'm happy to share with you the data that has been provided in these research studies of how AI has improved diagnosis to the point of, even when surgeons or radiologists or people are looking, thinking something is going on, and the accuracy of AI assistance has been phenomenal. In fact, once this gets out there, the data, the research, and others incorporate it, and I think that they'll begin to see it's a tool that can optimize our efficiency. I know one of the problems across the country is radiologists. I did a topic on this a little bit ago too, just a couple of months ago. We've got such a shortage of radiologists, and we've got, predictions of more shortage coming. And then AI utilization in being able to look at those, x-rays that could say, yes, this is what this looks like, and pull the pieces together. I think there's a lot of fear around AI. The only negative that I've seen in the healthcare realm so far is it does hallucinate a little bit.
Yeah.
And that would just be, when a physician is doing notes on a chart, history and physical, for example, the AI may say something that wasn't, the doctor didn't say, and that, yes, is a concern, but that just means you've got to go back through and double check that it was recorded or accurate. But I haven't seen any red flags to me that would scare me in the realm of patient safety.
I'm sure the Vedic astrologers would have something to say about that, that the error was actually inside your star chart, not necessarily within the diagnosis itself. It hallucinated in order to fulfill the divine plan. That's a little bit of sideways stuff. So let's talk a little bit maybe about preventative planning. What does that entail with sitting down with your family members, whether it's an aging parent, whether it's someone in your family suffering from an illness, a partner, all of that stuff? How do you create an environment which can foster an honest discussion where people are, because essentially we're dealing with a very delicate topic. Nobody wants to think about their death. Nobody wants to think about medical issues. I think it becomes more and more prominent as people age. I see the languaging and conversation between 70 and 80-year-olds is very much different. Like 20-year-olds don't think about they're ever going to die. 70 and 80 years old guys, who's going to die first? The coming freight train of reality gets a little bit closer and forces those, but you may not be in a position where you still have develop the tools in order to communicate the uncomfortable with those closest to you out of eliciting fear or creating disputes. There's an economic consequence, oftentimes insurance issues that may come to the forefront. Then there can be sibling elements that would enter into that conversation. So I got exposed to all that like really, really young. So I'm really tuned into some of the non-discussed topics of what happens when someone in your family is ill. What suggestions do you have for our listeners?
I would say start out with the easy conversations about discussing medications. Let's just say it's your mom and dad. Also accompanying them to doctor's appointments, taking notes, or if they're going in the hospital, taking notes. And this again is to bridge that gap of communication that sometimes just doesn't occur. And if you've got written in your notes, hey, the nephrologist yesterday said this, and now you're saying this, help me understand. And I think that brings up a point too in communication that you were discussing earlier, the 3 Ps that I like to share with people: be present, be polite, and be persistent. So, what I mean by be present, when there's shift change, when the doctor's going to visit, be present in your heart too. Assume good intentions. The polite is sometimes hard on both ends, the healthcare providers or patients and their family, because it's a high stress situation. And then be persistent. If you are really concerned about your mom, your dad, your wife, and you're not getting action, you need to escalate. So you've got the nurse, you've got the charge nurse, you've got the house supervisor, you've got the patient quality team, and you've got an administrator on call 24/7, so nights and weekends. So start those conversations with your family members with the easy stuff. Medications. Why are you taking this, mom? Do you want to try something different, or do you want to look at some other therapies? And then having those conversations. How do you want to live? Because, one of the parts of when I teach nursing students about this profession is moral distress. And so I say that because we in this country keep everybody alive, even when it is not optimal, or the quality of life has always been my tagline.
Mm-hmm.
I want quality of life. And so those conversations need to happen before an emergency, or before, yes, like you said, a lot of older people know that life is coming to an end, but sometimes this happens when we're young too. I don't want to be on a ventilator or have a trach or, on life support if there's no hope for me to have a meaningful life. And so that needs to be understood. And then you can put it in writing with the durable power of attorneys and all those legal documents that can protect you if you have an emergency or a terminal illness.
Yeah, and I dealt with that personally. When my sister, when her cancer became terminal, she made the decision on her own. This says, well, I'm not dying in the hospital. I'm going to come home. And so she stayed home, and that created a certain amount of stress and elements of just the care and the concern. And of course that elements, but it was a more eloquent exit from physical reality than it would have been had she been in the hospital and all of the elements. And, so these are not easy decisions, but you have to put aside a lot of your aversions to kind of go there. And what's really awesome about that, and I can share from that there then becomes a deeper sense of bond as a person is transiting, and you're not concentrated on the elements that you can't control. You are now in charge of the elements that you can, which is, are you creating the best environment possible? Are you having the conversations that you always wanted to get done and would regret if you didn't have? Are you getting unique insights? I've been around a lot of people in the palliative care situation, and there are insights that are available to you as a human upon your imminent demise that are extremely valuable and can serve those who are still with us into the future, and also create an environment. Because one of the elements that I think a lot of people don't know, many times the patient is only trying to survive because of the collective expectations of the family, and they're suffering exponentially more than you might be with the inconvenience of that situation. And providing an element where you can have that conversation, I think, is just really powerful and potent to not just quality of life, but quality of death.
Right? Yes.
Right?
For sure. My first job as a nurse many years ago, but was on the oncology floor. And we saw those dilemmas come up with families and, the patients that were really difficult to navigate sometimes, especially if they had not had that conversation.
Yeah. And I had that recently last year with a close friend of mine who he had gotten remission from cancer for 13 years. And then he get into trouble, he chose that he didn't want to go through the medical model that much. And he maintained his life, although at a diminishing pace, right up till about a month before he died. And then he was taken into the hospital for the last thing because he wasn't able to care for himself at the last part. He decided he wanted to take assisted suicide in the end because of the suffering that he was engaged in. Everybody got to meet with him. Everybody got to connect with him. We got to share these really emotionally touching moments. And then he said, I'm going out on my own terms, and passed relatively peacefully. That's legal in Canada, where the element happens. Now, there's a whole bunch of other moral dilemmas about the issuing of that from a government agency, et cetera, and what that could entail in the wrong people's hands. But what turned into a tragic situation became a beautiful moment inside of the connection that you can have for people. And he was really appreciative because it provided a space for people to have those real conversations, and he could joke about it and have fun and release tension. So there is a tension relieving element that I think a lot of people don't recognize that can happen in these conversations. What other advices do you have for people in regards to things that they might want to consider in their healthcare journey?
Gosh, let me think about that one for a minute. I think when you connect with people that have gone through something similar, I just added on my website a place where people can share their story and learn from others. I think support groups are amazing and wonderful. Find like-minded people that you can connect with that have a similar philosophy on health. And, maybe not doing the Western medicine route, as you talked about. I think there's a lot of value in that. It's a hard one to change because we have this mindset that the doctor knows best. This comes, I think, from the 1940s and 50s when they actually did house calls, and, when that doctor knew you really well. And that just is not the environment we live in any longer. And it really, as you said in the very beginning of this whole thing, is to advocate for yourselves and really figure out what kind of life that you want to live, and do everything in your power that you can while you still can, how to optimize that health and the autonomy that you have. I liken it to this, that the doctor really should be like the first mate on a ship. They've got the compass, they've got the maps, they've got their advice because they've done this for a while, but you're the captain. You get to determine where that ship is going and how it's going to get there. And if we acquiesce and give away that power, we're kind of stuck with what we agree to. So I know for myself, I want control. I want to be able to make those decisions that fit for me and not, 5,000 other people that the doctor may be treating the same way. If that makes sense.
Yeah, one of my mentors was a fellow by the name of Dr. David Hawkins, wrote a book called Power versus Force, and a subsequent series.
Love that.
And one of his books, Letting Go, is a really powerful element in dealing with these unconscious emotions. And when he was in medical practice, he talked about with terminally ill patients, he developed the first attitudinal healing clinic where people would come and meet. And then they studied the Course in Miracles book. The ironic part of that was 25% of those people who were terminally ill actually made a full recovery, which is pretty profound, because I think a lot of people don't understand that the psychosomatic elements may be a trigger within the disease as an influential factor, which is not studied in regular medicine. And so this is where, and he was an MD and a psychiatrist of one of the highest developments. So these elements contributed to some insights that were really powerful, and created another way to connect not around the disease or the condition, but around the social cohesiveness. And of course, all the longevity studies suggest that social cohesiveness is one of the primary drivers of longevity.
Yes, I actually met him. I went to a conference years ago in Las Vegas where he was speaking. What a character. I mean, he was an
Yeah.
amazing man.
Yeah, I went to such a ton of his conferences because I couldn't get enough, and they're all on. By the way, they're all on recording. I think on verituspub.com. You can go and get any of those things, and they're just so profound because he really, as a psychiatrist, understood the workings of the mind and the psychology and the emotion on such a really great level. He just really could give practical advice that you might not have available. So if you're more deferred to an authoritative process, well, why not access an authority like that? Or in this case, because I think what's really profound about your book is you're addressing these issues as they are right now in society at this moment. And people should pick up a copy. Where can people reach you on your website, other information, find out more? If there's anything that we didn't cover that you want to cover, can you please just do an unabashed promotion of everything that you're doing? Because I've been in these situations and I've counseled hundreds of people who are facing those situations. And I'd love for them to have your resource so that they know how to navigate that for themselves.
Thank you so much. My website is Dr. Julie Siemers, Siemers, and I can give you all this for the show notes. You can find blogs I've written, articles that I've written. My TEDx talk is on there, as well as I've created courses for nurses in the hospital. Because what I've also found in the research and being in nursing education was pretty shocking when I found, but the nurses are not getting the education that they used to, and they're not safe, competent, or ready for practice. And that, again, is why I'm trying to empower and educate and inform patients and their families, because the healthcare team really does need your help. Back in 2006, there was a big study of over 5,000 newly graduated nurses that had passed their NCLEX and got their license over 26 different states and 141 different schools. And it was a 5-hour exam that ended up showing part of it was written, part of it was application based, like in the simulation at the bedside, simulating a patient. They found only 35% of those nurses were safe, competent, and practice ready. A decade later, it had fallen to 23% in 2016. It was repeated in 2021. Take a wild guess.
Under 20?
9%.
Whoa.
Yes. We have a clinical judgment problem, and we don't have nurses staying in the profession. When I went from medical surgical unit to ICU, we had nurses 15, 20 years experience helping me learn how to take care of ventilators and balloon pumps and multiple drips, all those things. Right now, nurses are leaving the profession after 2 or 3 years because the work out there is so insane, and patients are so sick. So again, that's why I say we've got to arm ourselves with as much information we can to take care of ourselves and our families and advocate.
It also goes back to those 3 Ps, recognizing that person is doing the best they can with what they've been given and being present and polite and persistent as an advocate to assist them and provide them these reference points that allows them to make better judgment can be helpful. So they're seeing you not as an adverse element to it, that you're helping for them. So my mother is really good at negotiating those conversations. My father's terrible. I'm somewhere in between. So thank you for that extra insight. I really appreciate that. Where do people get all your book, your website? Oh, can you say that again?
drjuliesiemers.com. My book's on Amazon as well. One other thing I'd love to share with your audience is the cuss words. So when you want to be persistent and elevate your concern, the 4 things you can say is, I'm concerned, uncomfortable, scared, and I feel like this is a safety situation. So for example, you could say, I'm really concerned about my mom. She just doesn't look right. She's pale. She's breathing a little faster. Something's not quite right. Those 4 key words should really grab the attention of the healthcare provider or healthcare professional to then take further action. And then you escalate if you don't get the response that you want. Now I'm really uncomfortable. Something's wrong, or I feel like something's wrong, or I'm scared. This doesn't seem like my husband.
That is so beautiful because it opens up a dialogue and it also draws attention to elements that might be oversight when you're dealing with a floor of patients and all these elements and whatever you might be coming from. And I think a lot of people don't realize the type of pressure that nurses are under. And oftentimes, most hospitals that I've seen don't have enough nurses. I was really lucky when my recent stuff, we had an abundance of nurses in a relatively local hospital, and it was like the inversion of everything that we set up. But we advocated for it, and they were really responsive to it, and we had a great time, even though it was unplanned.
Right. Well, good. I'm so happy for you. Mm-hmm.
Yeah. This has been super informative, and it's a topic that I haven't discussed prior on the Awesome Health podcast, and I hadn't shared those stories. So thank you for providing a space for that, and as well as for doing the work that it takes to compile all this data, put it out for people, put a book out there, do a TED Talk. I mean, this is really great. So for all our listeners, pick up a copy of Surviving Your Hospital Stay. Today's guest was Dr. Julie Siemers. I'm Wade T. Lightheart, and I want to wish you the best of health. Keep advocating for you, your family, your team. Preparation is the key. Have those hard discussions, and you'll find that when you do so, you'll create a deeper sense of connection and a sense of serenity. And I think that's something we can all benefit from. Thanks so much from Awesome Health, Bioptimizers, and all of our family to yours. Take care.
And now for a Bioptimizers fixed digestion tip, rapid cheat meal relief. Research shows that cheat meals can actually be an effective way to boost your metabolism. One key weight loss hormone, leptin, can be increased by up to 30% following a cheat meal. The challenge with the cheat meals is that all those extra calories and lower food quality can be hard to digest, which means you could be totally sidelined with a food coma after big cheat meals. The solution is to take strong digestive enzymes like masszymes, which will help rapidly digest and break down the extra food. 3 to 5 capsules before or right after your cheat meal can make a huge difference in how you feel following the cheat meal. If it's a cheat day with multiple large meals, you might want to go up to 10 capsules or higher to help you power through all that food. To save 10% on masszymes, go to masszymes.com. That's MASSZYMES.com and enter the code CHEAT10 at checkout.
Thank you for listening to the Bioptimizers Awesome Health Podcast. You can find more information at bioptimizers.com.